Well, hello, followers of Neuro Takeaway. Today we have the great privilege to receive another outstanding radiologist that, unlike our previous guest, not only is he a radiologist, but he is an expert on head and neck radiology. His name is Professor Suresh Mukherji. Suresh did his residency on radiology at Harvard Medical School, at the Brigham Women's Hospital in Boston. He did his residency, his fellowship on head and neck and neuroradiology at the University of Florida. Now he is a professor of radiology at the University of Michigan and also at the University of Marion in Indianapolis. He wrote books, he published a lot, and he is also a member of the board of some of our most important magazines of AJNR and MR Clinic of North America. And after meeting him a number of years ago, I can say that he's an outstanding teacher and a nice person. So without further ado, let's go to the interview. Hello, how are you doing, Suresh?
I'm doing great. How are you?
Very well, thank you. Thank you for accepting the invitation. It's an honor to have you here. You were in Buenos Aires. When did you come to Buenos Aires? You remember?
Yeah, I do. I think it was about, I think it's about 6 years ago.
6 years.
And yeah, and it was part of the RSNA visiting professor program.
Yes.
So I had the privilege of coming down to Buenos Aires, and you treated me like, everyone treated me like a king. It was fantastic.
Yes.
I got to meet some wonderful people. I got to see some of the fantastic institutions, but most importantly, I got to experience the warmth and the friendship of the Argentinian culture. And
you ate well. Did you eat well? Yeah.
Yes, very well. I ate well. I drank well. I
remember.
did everything well. And so part of the the privilege of coming down there was meeting so many nice people, and I struck up the the relationship with Martin, and he and I are still kept in touch. And it's been as a teacher, it's been really fun to see someone like him who has energy and enthusiasm and knowledge and wonderful personality just flourish. So he and I have had a wonderful 6-year relationship of continuing to collaborate. So yeah, it was a great opportunity.
He's a great person.
Yeah.
Well, to kick off with the interview, I would like to ask you, why did you decide to become a head and neck radiologist?
Okay, well, the reason why I became a radiologist is that I trained, went to medical school in the last century. So I hate to say that, but I went to school in the last century, and in the last century, MRI was just coming around. So I remember sitting in medical school and I saw this picture of the brain, and I thought that was just amazing to actually be able to look in the human body at that time when we really had limited ways of doing it. And it was pretty obvious to me at the time that the future of medicine was not going to be indirect ways to make diagnosis, but literally the ability to look inside the body and to see what the causes of various illnesses and maladies were. And so that's something that occurred to me back in the late 1980s. So I went ahead and focused on radiology. I was fortunate enough to get into radiology. And I remember on the first day of my residency, I was on the neuroradiology rotation. And I remember the fellow at the time and the attending at the time taking a paperclip, because we didn't have PAC stations. We had alternators, and we had films. So for those of the millennials out there, you can Google film and see what it looked like. Yes. But the way we would look at things, we use things like grease pencils, and for really fine, intricate details, we would use our high-tech pointers, which were paper clips that we would unravel, and we would point at different types of pathology. And so on my first or second day of neuroradiology, people would look at the brain CT and they would show the brain, but really what's fascinating me is that one day they would start showing the various foramina of the skull base. So I remember them showing me foramen ovale and foramen spinosum and the jugular foramen and the temporal bone and the ossicles. And I think what was interesting is, first of all, they said, well, nobody really likes this. It's really hard. Nobody wants to do it. So that piqued my interest. And then secondly, it was a nice link to medical school, where I realized that a lot of the anatomy that I learned in medical school was now pertinent to clinical care.
Yeah.
So I think it was those two factors that kind of drove me. I think part of it was it did emphasize the importance of learning anatomy in medical school, but also it was a challenge. It wasn't the easiest area to get into. People always, just like when I became a radiologist, people question my decision for radiology in medical school. Now people question my decision to do head and neck radiology when I became a radiology resident. So, you know, I tend to take the path less traveled.
Yeah. You know, there are some gray areas between neuroradiology and head and neck. What are the boundaries, in your opinion?
Right, that's a wonderful question. So again, when I trained in the last century, when I was a resident, I did my residency at the Brigham, like you said, and then we would rotate over at the Massachusetts Eye and Ear Hospital. And there was a society at that time called the American Society of Head and Neck Radiology, which is still now in its 50th year. It's over, I think it's 52 years now. And that was founded by radiologists that never really had formal training in neuroradiology. They were essentially trained in general radiology, and basically they learned it from the clavicles up. So they were trained as general radiologists, and they kind of moved superiorly. And then over time, head and neck became more affiliated with the brain. So you had this combination of individuals that learned it from anti-gravity, going from the bottom up, versus gravity from the top down. And I remember I was always told, I shouldn't say told, but strongly suggested that in order to do head and neck, you really need to do 1 year of neuroradiology. And so over time, we are now essentially trained as head and neck radiologists through neuroradiology, and through our fellowship programs in the United States, and we called it Certificate of Added Qualification, but through our boards, our subspecialty boards, head and neck is now included as part of our neuroradiology training. It's one of the 3 pillars. So there's brain, spine, and head and neck is one of those 3 pillars now.
Mm-hmm. But for example, if you have a study of the orbits, who reads that study, the neuro or the head and neck?
Oh, for me, it's whoever gets it first. To others, it's whoever's on vacation gets it when they come back from vacation. So I guess it depends on who you ask.
Okay.
I think the orbits is a sort of an overlap, but most places don't have dedicated head and neck people. So in general, it falls to the neuroradiologist, and if there's someone that really does have a passion with head and neck,
yeah,
which is what I do in my practice now. They try to send all of the orbits to me now. We have a lot of neuroradiologists, but you know, my role is as director of head and neck imaging, is to try to read as many of those as I can.
That's what happens here too. I'd like to ask you a personal question. As a Hindu descendant, did you have to face kind of extra challenges in the US to become a top of the list radiologist as you are?
Yeah, it's a great question. And the answer is yes. You know, I think when I grew up, when I moved here, and it's a wonderful question, something that I think about, but no one really has the insights to ask. So when I came here in the 1966 or 1967, in the United States, that was only about 1 or 2 years after the Civil Rights Movement was passed. And, you know, the United States has different geographic locations, and I grew up in the South. And the South tended to be, if you will, a little bit more conservative than other places in the United States. So, you know, just looking at me, people can figure out that I didn't grow up in the United States, and we were also living in a more conservative area. So, and there wasn't the level acceptance. I'm not saying that there's a full there's certainly not full acceptance of different cultures and races now in the United States, by, as you know, by the recent events, but even there's much more tolerance now than it was 60 years ago. So yeah, I did face those. And when I grew up, it was more, well, that's just the way life is. But sort of looking back on it, it did have a dramatic effect on me, I think, regarding my social interactions, how I interact with people, the trust I have when I meet people, so on and so forth. Because when you do meet people and you don't know how they're going to react to you, sometimes violently, sometimes verbally abusive, it does have a lasting effect on you. How it motivated me was, there's an old saying, when life gives you lemons, you make lemonade. So I had one of my mentors at the time, I played a lot of sports back then, I still try to, and I played a lot of baseball. And one of my coaches there was African-American, who played baseball before Jackie Robinson became the first African-American. And so the advice that he gave me is that he faced it worse than I did. But, he always said, in general, the US tends to be a meritocratic society. And you can either say, all the chips are stacked against me, so I'm going to give up. Or his advice was, if you are in a disadvantaged situation, you have to be twice as good as the people around you. So if someone writes 100 papers, you have to write 200 papers. If someone writes 2 books, you have to write 5 books. If someone gives X lectures, you have to give twice as much. So you have to be twice as good. So instead of looking at it as a negative, saying, I'll never reach it, it just inspired me and drove me to try to achieve a certain level of, if you will, excellence that I may not have otherwise able to achieve if I didn't have those unique experiences.
Nice way to face it. Thank you for answering the question. You were one of the authors of the AJCC Cancer Staging Manual, and I always wonder how is to write these manuals that then are going to be followed by everybody in the world. Do you agree on everything? Are there any arbitrary decisions? How is that?
It's a great question. And I've been doing that since the 5th edition. So it's been about 20 years. So I've been able to see the process evolve. And, for me being in academics, and especially in imaging, number one, the first step is to convince people that imaging is important. And when you look at the AJCC, those of us that are, if you will, on the forefront of these techniques, that have the best equipment, that have subspecialty training, we are about 5 to 10 years ahead of everyone else. So we know it can be helpful. But when it comes to AJCC, one thing that I learned in the process was you have to be patient, and you have to understand what the goal of the AJCC staging system is. Because the AJCC staging system is not meant to provide the most accurate information and up-to-date information for staging in a single institutional tumor board. Rather, what it's trying to do is provide certain guidelines and standardization of staging and treatment globally. Mm-hmm. And, at the big centers in Argentina and in the United States and in Europe and Asia, they have access to the best expertise and the best equipment, and that knowledge base is wonderful. But in my travels, I realized that there are some parts of the world that may not have 128 detector CTs or 3 Tesla MRs, or they may not even have MRs at all. Mm-hmm. So the challenge is how do you create a certain level of uniformity such that you can say to a patient in Central Africa, that they can be treated similarly to someone that is going to be treated in the United States. It's hard. So I remember when I first got on it in the 5th edition, I wanted to make all these changes. And what was said to me was, yes, Suresh Mukherji may be able to see that, and you have the ability to do that. But the people, maybe in remote parts of the world can't do that. So it's not ready yet. But over time, and with persistence and with evidence-based approach, if you look at, for instance, some of the things in the larynx cancers. So if you look at things like erosion of the inner cortex and the outer cortex of the cartilages, the only way that can really be determined over time is through either performing a CT or MR. And that was finally integrated into the 7th edition. So we went through the 5th edition and the 6th edition, so we had a 10-year lag. But over time, as the technology became better, as there was more data indicating that imaging was good enough, then we were able to make those changes. So if you do look in the head and neck staging system and you read between the lines, there are certain areas where it implicitly says that imaging is necessary in order to make the most accurate staging.
So it's like a process of convincing little by little all the other specialists, no?
But then you have to look at the big picture, because the big picture is basically standardization of tumor assessment. But also, as important is that when new drug trials come out and you're trying to compare different treatments, you want to ensure that treatment, if there is a treatment that's going to provide a better outcome, you need to make sure that there is some type of consistency regarding staging, such that if you see a better outcome with a certain tumor, then we really have impacted how, in a positive way, how these patients are treated with these new modalities. So that, again, that's another function of the staging system that we have to keep in the back of our mind.
Right. Regarding our head and neck reports, sometimes I wonder how thoroughly do we have to go. For example, let's say in the sinus, parasinus cavities, do you use the close rule on each and every report that you perform?
Yeah. No, I don't use the close. I don't say, 1, 2, or 3, or close. Oh, you mean close. I see. With Keros, I don't talk about Keros. In general, I don't really use it as the close. I think it's a great way to approach it. What I do in my reports is it's sort of a surrogate. So what I'll do is I'll talk basically the frontal sinus, the maxillary sinus, sphenoid sinus, anterior skull base, and then talk about the brain. I basically have a bit of a standardized report that force functions me to look at everything. So if you want to use close, that's fantastic. The main thing is to make sure that you have some type of consistent process to interpret these different areas. So everyone is going to miss things, but if you can create some force function way to look at everything, that's where I think that type of construct is helpful.
Right. ADC and diffusion is extremely important for differentiating malignant versus benign. But what cutoff do you use on your daily practice for that?
So I think we talk about thresholds. So in general, 1.0 is a threshold. But the challenge that I have I looked at diffusion this way. It's not an end all, but it's just another imaging sequence. So for instance, back in the last century when MR first came out, there was all this information or all this hope about one sequence being the gold standard. But eventually what we've learned is that each sequence provides a certain amount of information. So the challenge with diffusion for me has never really been that cutoff, but it's the negative predictive value and the noise that's associated with the studies once you get below the skull base. So what I mean by this is that if I see a mass on my standard sequences and I'm not sure whether it's benign or malignant, then I look at the ADC values, and in general, if it's below 1 to 1.2, if it's dark, then I know it's probably malignant.
Okay.
But the challenge is the smaller the lesion gets, and I look at the diffusion, the smaller the lesion gets, the lower my negative predictive value and positive predictive value are.
Okay.
And my concern is that if we start talking about thresholds and we're looking an area below the skull base, which is more fraught with artifact, and then you see something on a standard sequence and it's small, and you say, but the diffusion doesn't show, the diffusion is not high or it's not low. What I'm concerned about is that you don't have enough resolution to really make an accurate diagnosis. So that's why if I have a lesion that's clearly visible,
yeah,
and then I look internally, and then I see the diffusion value is less than 1.21 or 1.2, then I'm very comfortable saying that would be my threshold. But I'm a little bit reluctant to throw out a number, because what's most important for me in diffusion is the resolution.
Okay. Okay. Interesting. And speaking about diffusion, what does it mean when we find that the lesion switch from restriction to facilitation during a treatment? How do you interpret that?
Yeah, that's a great question. It really depends on when you're making the measurement, at what time period. So the way that I look at it is that I've always looked at it that if you have a tumor that starts with low ADC and you treat that tumor, and that tumor changes the ADC value, so the ADC gets higher,
yeah,
it just means that somehow it's being affected by the treatment.
Okay.
And whether or not it's recurrent tumor post-treatment changes, you don't know. It's just being affected by the treatment. But on the other hand, if you look at the opposite, if you have low diffusion to begin with, and that patient is treated and there's still low diffusion, then that's really indicative that the tumor is not responding. So if there's no response and the ADC stays the same, then you know it's still persistent tumor. If that ADC changes and it gets higher, that doesn't necessarily mean that it's being properly treated. You just know that somehow the treatment is affecting that. And then you're still going to have to do your regular 3-month sequences. So the no change for me is more important than actually the change. Okay.
Interesting. We all know that it's very important to differentiate suppurative adenitis from an abscess, but sometimes we have trouble with that. So what do you have any rule of thumb for different?
Yeah, sure. In fact, I smile because literally 2 days ago, I faced this exact same question. Exact same question. So look, this is where radiology becomes more of an art than a science. First of all, suppurative adenitis is what you're referring to is retropharyngeal suppurative adenitis. So you have suppurative lymph nodes in the retropharyngeal lymph node. There should be a suppurative adenitis or a suppurative lymph node in the retropharyngeal lymph node. And the retropharyngeal lymph nodes tend to be paramidline. So if you have a patient that has throat pain, that has a stable airway, and you have a purely isolated round lesion in the region of the retropharyngeal lymph node that has a central focal area of low attenuation within it, then that is suppurative adenitis, okay? And it is completely appropriate to follow that with imaging and also to provide broad spectrum antibiotics. The challenge is that if this breaks and extends midline, then you have expansion of that space. But the challenge has always been is how do you separate? Suppurative adenitis is a very aggressive infectious process. And because of the proximity to the retropharyngeal space, you can oftentimes get edema/effusion in the retropharyngeal space. And that's where it becomes a little bit challenging to separate effusion from abscess.
Right.
So this is my rule of thumb. For me, like the case I saw the other day, you know, I told them, actually, I think what ended up happening is that I think I told them they weren't having the right antibiotic coverage, because the patient was on, they weren't being treated for penicillin, believe it or not. So number one is make sure that the patients are being treated with appropriate antibiotic coverage. But if there's any doubt at all, it's probably better to go in and at least try to drain it from a medical legal aspect if the radiologist is uncertain or the ENT surgeon is uncertain.
Okay.
With the understanding that you may only get a half a cc or 1 cc of pus. But in experienced hands and experienced centers, the way to differentiate it is that you have a enlarged round area with a low attenuation in the region of the retropharyngeal lymph node, and separate to that, you have edema involving the retropharyngeal space. And if you look real closely in the retropharyngeal space, you have to look very closely. Sometimes you'll see the alar fascia, which separates the retropharyngeal space from the danger space. Sometimes you can see that fascia. Or if you look real closely and you do your imaging just right, you'll sometimes see a little vascular plexus that's bisecting that effusion. So if you look in the retropharyngeal space, you'll see it's expanded by low attenuation. And sometimes you'll see that little vascular plexus. If you see that vascular plexus, and I don't think it's ever been described because there's never been pathologic correlation, that is typically indicative of effusion. Because when you have pus in that retropharyngeal space, it is highly inflammatory, it erodes the alar fascia, it essentially eliminates that vascular plexus, and there's nothing there. Okay. So those are the small little pearls that I've learned over the last 30 years. And the reason why I smile is that this was first brought to my attention the first year of my fellowship back in 1992. So one of the first things that we did is that we did a couple of papers and presentations on separative retropharyngeal lymphadenitis back in the 1990s. And lo and behold, it's 2020 and we're talking about this. So what I would say is to any of the people that are out there that listen to this, especially if you're trainees or junior faculty, or if you just have a restless mind like myself, if you have an interesting case or someone presents you to write a little case report or something, that's why Martin and I get along so well, because he has a very inquisitive mind. I can assure you that if you write a case report or a small presentation and you look up and you learn everything there is to know about that, that piece of domain expertise that you have acquired will help you at some point down the road be a better radiologist. 100%. Because back at the first paper I ever wrote back when I was a fellow was on cavernous sinus thrombosis. So I always remember cavernous sinus thrombosis. You know, I always remember separative retropharyngeal lymphadenitis. I still remember my first paper was on rhabdomyolysis of the kidney. I still remember rhabdomyolysis of the kidney in a patient that had child abuse. I still remember that, and that was back in the late 1980s. So these things stick with you, and there are various ways to learn. So if you're trainees out there and someone presents you with something, you know, grab it by the horn, learn about it, because it would always stick with you. And I guarantee you, you will use it one day in your practice, 100%.
Good piece of advice. Speaking about fat-SAT sequences on head and neck, those sequences as Espero, for example, they have some flow artifacts in the vessels, but they are still recommended for detecting dissections, artery dissections. Why is that?
Okay, I'm so glad you asked that, because I don't. I don't recommend them. And I got into a debate when I was the division director at University of Michigan about whether to do fat-SAT or not. And I had, obviously have talented people that have strong opinions. And at that time, everyone was saying do fat suppression. So I went back and actually looked at the original article that was published in Radiology in the 1990s, and it was not a prospective trial. It was a retrospective study of about, I think, between 10 and 20 patients that said if they did do fat suppression, they could see the mural, the eccentric hemorrhage in the wall. And They never talked about artifacts. They never talked about prospective studies, nothing like that. And I've done 2 or 3 angiograms in the middle of the night for fat-suppressed T1 weighted images that said there was a dissection. And actually what it was just the normal, the luminal wall is vascularized. So if you suppress everything, then you can get that artifact, that dissection mimic artifact, just from fat suppression. In fact, I use that in one of my talks on mimics. So I'm glad you brought it up. I don't use it, but somehow it's one of these things that made it into the literature back in the 1990s, and now it's hard to put the toothpaste back in the tube.
Right. Oftentimes we have trouble with the interpretation of some tissue changes after radiation. For example, the muscle, the bone. How do you interpret those changes? What do you have to say about that?
Yeah. So you mean the bone or the muscles, or just the soft tissues?
Bone and muscles. For example, sometimes we have hyperintensities on stir on the muscles.
Right. So the way that I look at that is, in general, the head and neck tends to be symmetric, and what I'm about to say is information we typically don't have when we interpret them, but because the normal anatomy is symmetric, in general, the post-treatment changes tend to be symmetric. And the assumption that we have to make is that if someone has a head and neck cancer, let's say it's a larynx cancer or oropharynx cancer, et cetera, the dose that they're receiving in the visceral space and the surrounding tissues tends to be symmetric. So as a result, if I see a patient that has an oropharynx cancer, I just assume they got a symmetric dose. Now, if there are times, especially with IMRT and other dose-sparing procedures where there is asymmetric radiation given, then it makes it a little bit more challenging. But to answer your question specifically, is if I see symmetric changes, first thing I do is I look at the opposite side. And if everything is symmetric, then I sort of attribute it to post-treatment changes. The second thing is you have to do your best to get the pre-treatment studies. So always try to compare your post-treatment with your pre-treatment. That's going to help you out a lot. Where I've seen what you're talking about most commonly is and you specifically pointed here, right, around the jaw and the masseter muscle. When I see asymmetric enlargement, enhancement of the masseter muscle,
that's right.
The next place my eye goes to is the mandible. Because in general, radiation therapy does not cause an isolated myositis. Usually the myositis, the unilateral myositis that I see after radiation therapy is usually due to some type of early or late osteonecrosis involving the ramus of the mandible. Mm-hmm. So if I do see that muscle enhancing after treatment, then I have to look at the bone to see whether or not there's osteonecrosis. Similarly, if the patient is on some type of calcium supplement, we used to call it bisphosphonate-associated osteonecrosis. Now it's called medication-associated osteonecrosis. Anytime I see that, I also have to think in the back of my mind, is the patient on some type of medication that could predispose the patient to an osteonecrosis involving the mandible that could cause the muscle to have secondary involvement. So those are the things that go through my mind.
Excellent. And are there any upcoming breakthrough technique for head and neck?
Honestly, I haven't seen it. I think, if you're asking me my opinion, I haven't seen anything that's sustainable. And it's a little bit sad to me because, I started doing, like I said, I started doing MR and CT in the last century. And, in 35 years, especially with brain imaging, when I was at the Brigham at the time, we were doing T2s, we were doing T1s with and without standard sequences. So yes, we've added diffusion and we've added gradient echo imaging or some type of heme imaging, if you will, whether it's susceptibility or gradient echo. Yeah. Maybe a FATSAT here, but in general, it's still the same stuff that we were doing years ago. I think the diffusion certainly has helped. And I think, I think the susceptibility I think the gradient echo helps, especially in post-traumatic patients and looking for cavernomas. I think it's arguable. What do you do with the microhemorrhages you see on susceptibility imaging? I don't know. If someone's post-trauma, I'll say it. If someone has stroke, I'll say it. But even if you're trying to determine whether someone gets stroke therapy, if you say a microhemorrhage is that going to dissuade the patient from getting IVTPA? And you can have that debate. But as far as head and neck, I haven't seen much. And, I've been one of the culprits, right? So my background is looking at a variety of physiological and biological imaging techniques, over the last 30 years. So I've looked at, perfusion, I've looked at, spectroscopy, we've looked at a variety of nuclear medicine studies, looked at, some of the radiomics, and that really hasn't panned out. Mag transfer sort of came and went. I think as far as fundamentally new techniques, the only one that's made a difference since I first started, which was CT and MR, was PET-CT, obviously. So I think that's been a big breakthrough. But as far as new radiotracer concerns in PET, I haven't seen. As far as sustainable techniques, I think perfusion and diffusion help, but new things coming out of the pipeline, I just haven't seen it. And that's what worries me. When I look at the field of radiology, every 10 years we've had an incremental development. So, back in the 60s, it was angiography. Back in the 70s, it was CT. Back in the 80s, it was sort of ultrasound MR. In the 90s, it was PET-CT. In 2000, you can argue we became more efficient with PACS. In 2010, there was all process improvement. 2020, I think once we figure out how AI is going to help us be more efficient, I think that's good. But as far as a fundamental new technique that's going to push us forward and allow our reimbursements to go up for each incremental unit of work, I haven't seen it yet. And I've been looking for about 10, 15 years. All I've seen are things that are making us work faster and more efficient over the last 20 years.
Interesting. We have to wait. I know that you love teaching. What advice would you give to a young radiologist that loves head and neck imaging?
Yeah, so that's a great question. I appreciate the comments. I love to teach, and I appreciate the acknowledgement. The only I don't know if it's an advice. I can just tell you what I do. The thing about advice that works for the person that works for the person that's giving the advice, whether or not it's going to work for the person listening to the advice, it's hard to say, right? But for me, I think what has made me effective is not forgetting how hard it was for me to learn it. So, like, for instance, like head and neck anatomy. When I started my fellowship, I had no idea about the temporal bone anatomy. I didn't even know the ossicles. When I started as a fellow in head and neck, in neuroradiology and head and neck, I didn't even know there were two parts of the tongue. I thought there was a tongue. But then I found out there was a tongue base, and there was an oral tongue, and there was a root of tongue. The tonsils, I thought there was just a tonsil. I had no idea there was a palatine tonsil, then an anterior tonsillar pillar, and a posterior tonsillar pillar. So, I just remember I'm completely lost. I was in this fog. In some way, I figured it out, and I just remember how hard it was for me to learn, and what were the little steps over time that I had to go through in order to grasp the knowledge and then somehow convey it. So for young people that want to get into teaching, you weren't born with the knowledge, you acquired it. And sometimes you have to figure out what were the steps that you took to acquire that knowledge. And if you can be self-reflective and say, that's what it took for me to do it, and convey that to those trainees, I think that helps. Mm-hmm. And number two is there's nothing wrong with repetition. So for instance, if you go to a meeting and let's just say you go from a meeting from 8 to 5, and they're all half-hour lectures. So basically with a lunch break, you have 8 lectures in the morning, 8 lectures in the afternoon. That's 16 lectures over a 1-day period. And then let's say your conference is 3 days. All of a sudden you have it was 16 times 3. I have to get my calculator. I think that's 48, right? 48 lectures. There's no way you're going to remember that. It's impossible to remember all that information. So from an educator standpoint, is that I've always said there's a difference in giving a talk and teaching. So if I'm giving a 30-minute talk, I can try to impress the audience with as much as I know. And they're going to say, wow, what a great talk. Tomorrow they don't remember anything. Or you can say, I want that audience to leave with 3 pieces of knowledge that they're going to remember tomorrow.
Yeah.
And so there's nothing wrong with repetition, and there's nothing wrong with focusing on certain key points that the audience, who you have to realize is not head and neck, but these are probably people that are reading a brain MR one day, then the next minute they're reading an abdomen CT, the next minute they're reading a small part, musculoskeletal ankle. They may be doing a mammogram, and then they may be putting in a PICC line. That's the general practice. And they're not going to remember all the nuances. But if I can give them 3 things that they can remember through simplification and repetition that's practical, that they can implement in their practice, then I've done my job and I feel good about it.
Well, thank you. Well, we ran out of time, unfortunately. It's been a pleasure to listen to you as always. And thank you very much. I'm sure our audience will be delighted with your comments. Thank you, Suresh.
Thank you very much.